Good morning, everybody. My name is Chris Vincent. I'm actually clinical director at FEOPS. It's really my privilege and honor to introduce this session this morning in PCR valves. The theme of this convention with education FEOPS is Meet the Master in Digital Heart. And this morning on the Tuesday, we have a session on the learning predictive value of virtual implant in the mitral intervention in TMVR with MAC case as well. It's really my honor to welcome Professor Ronak Rajani. It's amazing because Dr. Rajani was just promoting recently Professor. Just big congratulations for that. We are very honored to have you in this call. You are from Guy's and St. Thomas in the UK. It will be a maximum 30 minutes session, including interaction. There are two ways of having interaction. The number one is the quick polls. You will have a couple of quick polls during the sessions, answering a little bit your personal intention according to those questions. So please vote on that moment, and Professor Rajani will comment on your personal opinion about that. The second way to have interaction is to use at the bottom of your screen the chat line. So please ask as much questions as you want. Even at the end, if it's coming late, we will continue to answer those questions afterwards with you. So I will manage those questions and I will summarize them and asking those questions to Professor Rajani at the end of the session. So it will be a very practical, case-based discussions with as much as possible interactivity. I want just now to show you the learning objective of the session. Okay, so at the end of this session, you will be able to understand the complexity of mitral cases with the different the difficulties and challenging you may have in these sessions, as you can see, to evaluate the anatomical complexity, to understand the role of patient-specific virtual implants in mitral intervention, to explore clearly all the functionality of FEOPS Heart Guide preoperative planning tool, and last but not least, to participate in this case-based discussion that outlined the clinical value of advanced preoperative planning. By saying so, I wish you a really great presentation, great convention, and Professor Rajani, I give you the talk. Thank you.
Okay, so thank you very much, Christian. I'm just going to share my screen. Okay, so right. Okay, can everyone hear me? So good. So we're going to make a start, and the whole purpose of this session is to really think about in more depth about the valve in MAC procedure, which I personally consider to be one of the highest risk structural interventions that we can currently do in the current era. Okay, so these are my conflicts of interest in terms of the honoraria that I've received, and I've received honoraria from GE Healthcare, Philips Healthcare, Edwards Life Sciences, Medtronic, and also Siemens Health and Ears. These are my acknowledgements. I work with a very talented group of interventional cardiologists who rely very much on the imaging that we provide them, particularly for the valve in MAC space, which is particularly a complicated area. So could we show quick poll 1 to start off with, please? So how comfortable are you in TAVI and MAC cases in making a sizing stroke position decision based on standard preoperative imaging? So if you could take a vote right now, that would be fantastic, and then we'll show the results of that and I'll continue. So how comfortable are you using your CT data and transthoracic or TOE data in making a call for interventional cardiologists as to whether or not the case is suitable for a valve in MAC? Okay, so not surprising, many of you are uncomfortable in terms of making a decision based on the CT or echocardiographic imaging, and I must say that's my experience as well. So when we first consider transcatheter mitral valve therapies, we have to understand that this is a very different prospect to transcatheter aortic valve implantation. And we need to consider a number or a host of different features that are not significant in TAVR. So first of all, the anatomy of the mitral valve is far more complicated. We need to consider the left atrium, the mitral valve annulus, the left ventricular outflow tract, the papillary muscles, the chordae tendineae, and also the left ventricular apex. But at the same time, we also need to consider the physiology of the valve and its effects. So how will the annulus deform with the transcatheter mitral valve replacement? How severe is the mitral regurgitation? What is the mechanism? And how can we best predict outcomes? We also have to be aware that there are a number of different devices competing in the transcatheter mitral space, all of which have their own specific geometric requirements. We know a little bit about the mitral valve for a number of studies that have been performed over the last 10 to 15 years. And a specific feature to the mitral valve is an area which causes often a lot of confusion, that most people consider that the mitral valve annulus area is largest during systole or end systole, but that's actually not the case. The largest mitral valve area is actually present at about 60% of the R2R interval on multiphase ECG gated CT. So in other words, early diastole. And the reason this is the case is that you get an area decrease of approximately 24% during systole, and that's because the mitral valve assumes the shape of a hyperbolic paraboloid. Now, we have good recommendations as to how we can standardize the assessment of the mitral valve annulus, and this is a slide from Blanca et al.'s paper in JACC Cardiovascular Imaging in 2015. And we can see that the mitral valve annulus can be designed as being a D-shaped annulus, whereby you can measure the septal to lateral distance, the intercommissural distance, and also the trigone to trigone distance. Now, this is important because it allows some space at the left ventricular outflow tract to try and mitigate for the biggest complication that we perceive, which is outflow tract obstruction. And what we would normally do is to place our crosshairs at the base of the hinge points of the anterior and posterior mitral valve leaflets and measure the perimeter and also the area of the mitral valve annulus. So here you can see me doing this on a standard cardiac CT dataset. I place the crosshairs at the hinge points of the anterior and posterior mitral valve leaflets, first in the 4-chamber view, then in the 2nd-chamber view, and then in the top left-hand image, you can see the D-shaped annulus. Now, from the D-shaped annulus, a number of different measurements can be taken, and this includes the area, the perimeter, the septal to lateral distance, and also the intercommissural distance. Now, the biggest concern with the majority of transcatheter mitral valve devices is largely the presence of outflow tract obstruction following device deployment. And this can be shown in this slide, that once you implant a transcatheter mitral valve into the mitral valve annulus, you can get displacement of the anterior mitral valve leaflet towards the interventricular septum, creating the so-called neo-left ventricular outflow tract. And this can result in physiological obstruction at the outflow tract level. Now, a number of different features have been proposed to contribute to outflow tract obstruction, and these essentially are summarized on this slide. You can see that device protrusion, device flaring, the aortomitral angulation, and also the presence of a basal septal bulge are all felt to contribute to the development of outflow tract obstruction. Now, this is just an example of how you can measure the aortomitral angulation. You can see here that the aortomitral angulation at end systole is 135 degrees. And generally, I would have a cause for concern once you get to less than 135 degrees. The more acute you get an angle, the greater the risk of outflow tract obstruction is going to be. Now, we've done a number of valve in MAC cases at Guy's and St Thomas's Hospital over the years, and our original approach was to size for our devices using the technique that I've just shown you on the preceding slides. And I must say that our experience was very mixed to start off with and very consistent with the international literature that's recently been published on the MAC registry data. So when it goes well, it goes fantastically well. So this was an example of a patient with severe mitral valve annulus calcification. You can also see that there's a TAVI valve in situ. Now, if you look at the short axis images on the right-hand side, you can see that there is dense confluent calcification occupying about 75 to 80% of the mitral valve annulus. Now, in this particular case, this was the world's first example of a lotus valve being placed in the MAC position. You can see that the final result was excellent. There was good conformity to the mitral valve annulus calcification, no geometric distortion, and indeed there was no significant left ventricular outflow tract obstruction. Now, bear in mind, the sizing for this case was done purely by CT analysis using the system that I've already shown you. And MAC does pose a number of problems. And where do you measure the annulus? Do you go through the middle of the calcium? Do you trace around the edge of the calcification? What about calcium blooming artifact? What about the circumferentiality and also the density of the calcium, and how will the calcium deform? So early on in our exploration of valve in MAC procedures, we used to use this standard sizing, but we also started to explore whether or not computer simulation would be of benefit in these cases. So what we did is we sent this CT scan dataset to our colleagues FIOPS in Belgium and asked them to see whether or not computer simulation with finite element modeling would have helped in this case to determine suitability. Now, this is just some more pictures of the case showing that the valve went in very well with no specific issues. Now, this was the simulation that we first had. So this is very early FIOPS data from our collaboration with FIOPS. And this probably spans back about sort of 7 to 8 years. And this simulation showed that the valve device, the Lotus valve, would sit very comfortably within this mitral valve annulus calcification, and that the mitral valve annulus calcification was dense, confluent, and also extended into the left ventricular cavity. So we had some hope that actually this potential technique would be of benefit in our patients. Now, bear in mind that this CT data set was interpreted and processed retrospectively after the case had been performed. So this was very early on in our experience. We then went on and we were buoyed by our good result with our first Lotus and MAC case that we wanted to try another. And once again, we did our standard sizing using the CT dataset, but didn't use computer simulation. It was too much in its infancy. Now, this case did not go very well. And this patient developed severe paravalvular regurgitation after the valve deployment. The valve started to migrate, and the patient needed to be rushed to surgery as an emergency that night, where Professor Bapat did his usual heroics and was able to stitch the Lotus valve and sort out the paravalvular leak. Now, the additional valve that went in was with a Lotus 27 millimeter, and we wanted to try and explore, would this result have been predictable if we used the same technique that we used for our first case? So once again, we sent our CT data set to our colleagues in FIOPS Belgium and asked them to do their computer simulation and finite element analysis to see whether or not the result could have been predicted and whether or not this patient would have been deemed to be unsuitable for MAC had we done more sophisticated analysis. Now here you can see that irrespective of the valve size type or size that we put in, whether it was a Lotus 23, a 25 or a 27 millimeter, irrespective of which size we used, there was always going to be a paravalvular leak at the anterolateral commissure. Now, we did some more sophisticated views, and we can look at this from a number of different angles using the simulations, and these were all consistent, that in actual fact, the case selection based on standard CT sizing indicated unsuitability for a valve in MAC procedure. So when TMVR is unsuitable, this was a perfect example of where the computer simulation outperformed a human analysis in predicting what the patient procedural outcome would have been. And the reason being is that when we do our standard CT analysis, this is based on geometric data and does not account for the tissue properties and how the calcium will deform following deployment. And we can clearly see that there was a risk of device instability and a severe paravalvular leak, as was demonstrated from the clinical outcome of this case. So looking at the results of the first two cases, we then started to use the FIOPS platform prospectively. So we did our CT analysis, we had an idea of what size and what type of valve we wanted to use, and we then started to send our CT datasets to support our clinical decision making, remembering that this was still in its infancy in terms of its pipeline of development. So we had another case of valve in MAC being a consideration, and we took the CT data set, we sent it to our colleagues in Belgium, and we asked them to perform some analyses based on a predetermined valve size that we had given them from the standard CT analysis. We wanted to know at what size and what height the valve should be deployed, whether it should be in a high position, a medium position, or a low position. We wanted to have detailed analysis of what the valve would look like from the left atrium in all three of these positions. So once again, the high, medium, and low positions, and also what the view from the left ventricle would look like. And what we're really looking at from these images, they're not just pretty or fancy pictures, is we're actually looking to see whether the skirt of the device is in close apposition with the mitral valve annulus calcification, and whether or not we can appreciate any significant gaps between the skirt and also the device and the mitral valve annulus calcification, and also the degree of circumferentiality of the mitral valve annulus calcification. Now, this was the views from the aorta because we wanted to measure the neo-left ventricular outflow tract area following calcium deformation. And we can see that irrespective of where the device was fitted, the calcium deformed reasonably well, but the concern was going to be regarding device stability in this case. So here we can see the computer simulation. This really portrays very well about how finite element modeling works. So when we use finite element analysis, we are accounting for the tissue properties and looking for the calcium deformation. How is the calcium going to sit once the device is actually deployed in the mitral valve annulus calcification region?
Professor Rajani, can I just interrupt you 1 minute?
Sure.
There is a question from the audience exactly regarding what you said now in the calcium. The question is, how do you know how hard is the calcium or the calcium will be? Hence, how to predict the skirt/calcium interaction?
Absolutely. And so I think that's a fantastic question. And that is the problem that is posed to many CT experts around the world. Some people have looked at Agatston's score of the mitral valve annulus calcification, the density and the mass, but it seems to correlate very poorly in terms of procedural outcome. There's a modest relationship. And that's where specifically, I think, techniques that use finite element analysis that accounts for the density of the calcium. And based on the density of calcium, you can predict how the calcium will deform and how the skirt will fit. And it's the whole principle of why we advocate the use of this technology, because it enables a prediction based on the tissue properties. And it's the tissue properties not only of the calcium, it's of the mitral valve leaflets, the primary chords, and also the left ventricle. So you're actually modeling to see how the tissue properties will behave using this technique. It's very similar to other propositions from other software vendors, which is actually just placing a valve inside the mitral valve annulus calcification, but not performing the finite element analysis to account for tissue properties. So we then published our 3 results that I've shown you in the Journal of Cardiovascular Computed Tomography, and started to believe that actually this technique should augment clinical decision making. So FEOPS is not standard CT processing that you see on other software vendors and other platforms. So what essentially is happening is that you're producing a multi-phase ECG-gated cardiac CT, and my steps would be to do the standard analysis that I showed you on the first slides to try and predict what type of size valve that should be deployed in this patient, in a specific patient. This information I would then provide to colleagues in Belgium, our FEOPS colleagues, who would then take the CT data set. They would do a CT-based 3D reconstruction, do automated segmentation, and then do a finite element model and do the finite element analysis simulation. Now, the finite element analysis simulation is accounting for the anterior, posterior mitral valve leaflets, the annulus calcification, and it looks to see how the calcification will deform and whether or not the valve will be seated appropriately and whether or not we can anticipate any significant paravalvular leaks. Now, by using this technique, you can also position the valve at various different heights. So the communication I would normally have with my colleagues would be, could we do a 50 to 50% deployment? So 50% in the left atrium, 50% in the left ventricle, a 40-60% deployment, 40% in the left atrium, 60% in the left ventricle, and a 60-40% relationship, 60% in the left atrium and 40% in the left ventricle. So looking at various heights of deployment to see the influence that will have on the neo-left ventricular outflow tract. So here you can see us doing this here. So position A, position B, and position C are various heights of deployment of the valve in the MAC position. And I think you can appreciate that this influences the neo-left ventricular outflow tract quite considerably. And you reach a critical point at height of deployment where you start to impact upon the neo-left ventricular outflow tract area. Now, once this information would be received, this would just be guidance. You would then make a judgment call as to what you would advise your interventional cardiologists as to whether or not the case is likely to be suitable or unsuitable for a valve in MAC procedure. Now, this is an example of a fascinating case that we've recently done. This was done earlier this year. It was published in JACC Case Reports. And this is an example of a case that we did simultaneous TAVR and valve in MAC at the same sitting by Professor Redwood. And the question is, would this patient be suitable for a valve in MAC procedure? Now, on the platform or the FEOPS viewer, you can see me actually moving and rotating the images around, and you have the option to move the device at various different positions that I've shown you, A, B, and C, and then to measure the neo-left ventricular outflow tract area and how it changes at these various different positions. And we manipulate the data reasonably quickly in real time. We can select whichever phase that we want. The normal standard phase to use is end systole, because that's when the LV cavity is going to be smallest, and that's what's going to influence the neo-left ventricular outflow tract. And you can see that the neo-left ventricular outflow tract area is about 202 millimeters squared, with a cutoff of a threshold being normally about 180 millimeters squared as being a cause for concern. So I was reasonably confident, based on this information, that we could safely proceed to perform a valve in MAC procedure. Now, the proof is always in the pudding, so to say, and how can I be certain that the results I'm getting from the finite element analysis are concordant with what we could expect to experience with real life practice? So what we can do is to measure the neo-left ventricular outflow tract area from the finite element simulation from the pre-procedural CT data set, and in a cohort of patients, we also compared this with the post-procedural CT neo-left ventricular outflow tract area. And we can see that there is an excellent correlation. We have one outlier, and that was predominantly down to the CT quality and a movement artifact on the CT scan acquisition, that there is almost a linear relationship based on the FEOPS prediction for the neo-left ventricular outflow tract area from the pre-CT scan compared to the actual results that were obtained on the post-procedural CT scan. So a very robust technique in terms of predicting neo-left ventricular outflow tract area from the pre-procedural CT data set. Now, this just shows some pilot data which shows how the calcium deforms. And we look to model how the calcium would deform from the pre-procedural CT data set, and also what the model would actually predict in terms of calcium deformation. And once again, the modeling and the finite element analysis predicted how the calcium would behave with an excellent degree of certainty based on our pre-procedural modeling. So how do we use this clinically? So I'm going to give you a case example now. So we had an 83-year-old man who had a bioprosthetic aortic valve in November 2016, had significant calcific mitral valve disease and mitral valve annulus calcification, prostate carcinoma, and was in NYHA class 3. Now, this was the imaging. You can see the transesophageal echocardiogram showing significant mitral valve stenosis and also significant mitral valve annulus calcification. These were the 3D TOE images showing severe mitral valve annulus calcification with a very ellipsoid shape. And I think that can be appreciated exceptionally well on the 3D TOE images with a reduced mitral valve opening orifice area. And you can see us planimetering on the 3D MVA what the mitral valve area was and also the mean gradient. This was the CT imaging. So there was an intermediate aortomitral angulation. There was an ellipsoid and incomplete MAC, but there was an adequate height to the papillary muscles. So could we show quick poll 2? So which of these following statements is true? There is insufficient calcification for a valve in MAC. There is a risk of dislodgement. There is an acute aortomitral angulation, risk of left ventricular outflow tract obstruction. The annulus is ellipsoid, so there is a significant risk of paravalvular regurgitation. Or number 4, it's not possible to be certain of a successful outcome. So if you could all vote, that would be fantastic. And then we'll show the results in 30 or 40 seconds. Okay, so if we could show the results now of the poll. Okay, so we have a mix, and I think this also shows the uncertainty that I have with these type of cases. There is no international expert who can tell you with any degree of certainty as to whether or not a case is suitable for a valve in MAC. And we have a mix of responses: insufficient calcification, risk of dislodgement, acute aortomitral angulation, ellipsoid annulus, risk of paravalvular regurgitation, and also a quarter of the respondents felt it wasn't certain to be certain of a successful outcome. Okay, so geometric sizing at centers of excellence. So if you look at the MAC registry data, and this is the first paper that was published by my colleague Maya Guerrero in JACC Cardiovascular Imaging in 2016, There were 64 patients at 32 centres using a variety of different devices. 28% technical failure, 17% requiring a second valve, 9% of outflow tract obstruction, and there was a 30% 30-day mortality. Now, if you look at the one-year data, the one-year mortality was about 50%. So these are high-risk cases that do require very sophisticated analysis. So do I think we can do better? I think we can. So the current problems is that the current planning that I've shown you is based on geometrical or anatomical planning alone. The volume remains small. They're done, we do about 4 to 5 cases per annum, and we're a large volume centre for complex structural interventions. There's multiple competing devices. It's considered to be a specialist procedure, and the results are only modest. Now, the TMVR challenges is that we are dealing with complex mitral valve anatomy, reduced LV function, outflow tract obstruction, prediction of LV recovery, there's blood stagnation in the left ventricle, propensity to form thrombus, it requires personalized planning. The mitral valve annulus is very dynamic with a shape change during the cardiac cycle, and it requires a high degree of patient selection. So what did we do in this specific case? So we did our finite element modeling, and we did the mitral valve reconstruction. We looked at a deployment at a low, intermediate, and high deployment, looked at the left atrial views that I've already shown you to see how the valve would conform to the mitral valve annulus calcification, took some views from the aorta, and also predicted the neo-left ventricular outflow tract area using the technique that I've shown. Now here we can see that the neo-left ventricular outflow tract area is predicted to be sufficient for this patient, and that actually on the previous views you've seen that the device would conform to the mitral valve annulus calcification once it had undergone deformation. We looked at the calcium behavioral forces, and you can see that the calcium is deforming to the valve. And so we decided to proceed to a 29mm Sapien 3 valve. We felt that this was ideal at a medium implant position with no risk of left ventricular outflow tract obstruction, no risk of dislodgement, and no risk of paravalvular leak. Now, planning is one thing. I can give a recommendation to my colleagues that you need to deploy the valve at a 50 to 50% ratio between the left atrium and left ventricle, but so far it's very difficult to be certain that the interventional cardiologist will deploy the valve exactly where I would like them to. So what we have been also working on is simulation fusion, and we recently published a couple of years ago one of the world's first examples of simulation fluorofusion. So we did our simulations with FEOPS, and we asked for this to be shared with us, and we were able to actually implant the valve, and you can see the Sapien 29mm valve implanted over here, and also here in the 3-chamber view, with also segmentation of the left atrium, left atrial appendage. We also made note of a few planning lines, and this is done with valve assist platform with GE, superior vena cava, inferior vena cava, the fossa ovalis, the optimal position where the valve would be deployed to give us the optimal result, and in the blue you can see the calcification, and this is what would be the anticipated final result. So this is also using the simulation results from FEOPS on the CT to be able to look at the optimal fluoroscopic projections. Now, on the left-hand side, you can see what the interventional cardiologist would have if there was no fusion available and no simulation available to them in the cardiac cath lab. On the right-hand side is what I call landmark fusion. So what we've done is we've done the planning lines: superior vena cava, inferior vena cava, left atrium, left atrial appendage, fossa ovalis, aorta. And here we can see the optimal superior deployment zone, optimal inferior deployment zone, and in the blue, you can see the mitral valve annulus calcification. On the left-hand side here, you can see no fusion. You can see the results with landmark fusion and also with volume rendered fusion. And I think that you can appreciate that by having all of the simulation and the fusion available, it really guides the interventional cardiologist to position the valve where the simulations and the projected outcomes are believed to offer or confer the best results. So here you can see the valve being deployed. We have very clear anatomical landmarks for our interventional cardiologist. So X marks the spot. Now, the final assessment to make sure that the valve is in the right place as predicted by the simulation, and we can see that our interventional cardiologists have deployed the valve at our 50 to 50% deployment ratio between the left atrium and the left ventricle at the targeted planning zone. Now, this was the final assessment on TOE. you can see that it is a well-deployed valve. There's no paravalvular regurgitation, well-seated, with no evidence of dehiscence or rocking motion of the 29mm Sapien 3 valve. This was a post-procedural CT scan showing that there's no significant neo-left ventricular outflow tract obstruction, well-seated device at a 50 to 50% deployment zone within the MAC. So if we could show quick poll 3, please. So based on the information I've shown you in our experience with FEOPS, I'd like to ask a question to the audience. Do you think that the FEOPS Heart Guide influences your results or planning for valve in MAC? Would it influence your decision? It would make no difference at all, or you feel it provides greater certainty for complex MAC cases? Okay, if we could show the results. Okay, so most people believe that using this type of platform, this finite element modeling, patient-specific modeling, would influence your decision making and would also provide a greater degree of certainty for complex MAC cases. I should say that this is now our standard approach for planning for all mitral valve annulus calcification cases, and it results in referrals being received from around the United Kingdom, where we would do this sophisticated modeling working in conjunction with FEOPS to better predict patient outcomes. I would say that actually, since we've started using this platform, we actually turn down far many more cases than we would have normally accepted, purely because we don't feel that the results are going to be optimal. So just to conclude, this is now our standard planning for cases at St. Thomas's Hospital. You will have seen some of this on our previous live cases over the preceding years. I personally believe, and I'm a strong advocate for computer simulation and bioengineering to predict patient procedural outcomes with structural heart interventions. I believe that geometric predictions for structural heart interventions are insufficient. I do believe we need patient-specific modeling, and it confers enhanced planning. It improves our certainty, and I certainly do believe that it augments our clinical decision making. So thank you very much. I would be open to any questions which FEOPS and Christian would be able to moderate.
Hey, Professor Rajani, thank you. So there is no additional question on the chat. So
I've convinced everyone.
It looks like you were or extremely clear, or you answered the question during the session. So I at least from my side, I would like to say thank you so much. We have learned so much with you. You know, we know in FEOPS we are an engineering company working hard on developing tools to develop simulation. But it's very important to understand from the clinicians you are, what are the needs and where to focus our special attention. And we really understand today, again, to this presentation, that the big focus on the mitral field will be on the neo-LVUT, clearly on the calcification, on the shape of the annulus. So all the things are extremely important to explore, and we hope to provide you additional good insight into that direction. I really want to say special thank you to you, Professor Rajani, for this really outstanding presentation, as usual, very clear, very well illustrated as well. So thank you so much for that. And for the audience, I wish you a very nice rest of the PCR valve this year. I think it's a very focused and a very well-organized session. So be sure that when you connect to the PCR main page, you go to the education section. In the education section, you will find FEOPS, and there is many more things that you can discover about us, publications, resources, the video, how to access that. And also it will be also possible for you, because all the sessions that we were organizing there, we organized almost 6 sessions, are all recorded, and that will be available also in the future. But I want really to finish by a big thank you for Professor Rajani. You did again a really fantastic job. Thank you so much.
Thank you very much. Okay, take care. Bye-bye.
Good afternoon. Bye-bye.